lateral bending of upper thoracic, left lateral bending.
Okay, we're going to do lateral bending of the upper thoracic spine. And in this case, we're going to use left lateral bending as an example. Just like we did in the middle and the lower thoracic spine, our segmental contact point is going to be the lateral aspect, in this case the left side of the spinous process. Just like we did in the middle and the lower thoracic spine, we recommend that whatever level that you're given, for the most part, we're going to contact the lateral aspect, letting the base of your thumb, in this case, spy over the inner space, feeling the spinous process below. In this way, you can actually feel the relative movement that takes place between the two. Just like we did with rotation in the upper thoracic spine, we're going to look at two things. We're going to look at joint play and end play. Joint play is that passive range of motion that occurs between neutral and pre-adjusted tension. So with regards to joint play, I'm looking to find out whether it's normal, whether it's reduced, or whether it's absent. And what you should feel is you should feel movement between the two segments. In essence, in this one, some people describe it as a kind of a buckling sensation. That as we begin to go through the movement, I should feel almost like a movement between the two segments, like a buckling in my thumb. That's what I should feel. That would be normal. As in lateral bending with the middle, and the lower thoracic spine, the spine is always going to feel like it moves somewhat away from you a little bit. That's going to be normal whether they're restricted or not. What the joint play will feel like, instead of the buckling, which you'll feel as the two will tend to move as a team together, that would be indication of a reduced or absent joint play. So being on the side, I'm going to take my indifferent hand and place it on the crown of the head, and I'm just going to passively laterally bend the head till I basically feel it pre-tension, which is just the stopping of the movement. And as I do this, I'm just going to feel the motion that takes place in the spine. You can probably actually see it here on camera, but I should feel a little bit of movement between the two segments. To assess end play, I first bring the joint to pre-tension. Well, how do I know where pre-tension is? There's so little lateral bending in the thoracic spine that by the time that you feel the spine begin to translate away, or you begin to feel it buckle, you're pretty much at that pre-tension. So my goal over here would be maintain the joint in pre-tension, and then from there spring that eighth of an inch to feel that resiliency, the give and also the recoil. The problem that we have in the upper thoracic spine is my stabilization hand is so far removed that when you stabilize the head and begin to spring through here, often your patients are going to complain that they have excessive tension in the upper cervical spine. That's something we want to try to avoid. It's okay for joint play testing, but for end play testing, I don't want to use this as my indifferent hand. Since my segment that I'm assessing is down here low in the upper thoracic, lower cervical spine, I also want my indifferent hand to also be down there. Concept you kind of got to get used to is like when we did lateral bending in the thoracic spine, we took, let's say the transverse processes are contacts, and to create this turning movement on the planes of the facets, we did opposite movements in both hands. For example, with left lateral bending, we came from superior to inferior, lateral to medial, and P to A, in this case on the left side. While on the right side, we came in the TVP, we came with that same plane coming from about, in this case, I to S, lateral to medial, and P to A. And our goal was basically to kind of, along the planes of the facets, which are at 60 degrees here, is to kind of torque the joint. So both hands were active in this one. Well, lateral bending is no different. The only difference is we're going to use a spinous process contact for one, and in essence, our mindset is to kind of think as if we're taking the TVP on the other. So what are your lines of drive, in essence? Well, on the segmental contact point, and the only one we'll ask you for the exam, since you're on the spinous process, your line of drive is going to be lateral to medial, in this case from left to right. The goal, though, if you're a different hand, we're not going to ask you what it's really doing, but your goal is, I'm going to traction up the plane of the facet. And since the planes of the thoracic spine are about 60 degrees off the transverse plane, predominantly it's almost a straight axial traction. And you'll learn that later with Dr. Hall's class when adjusting in the upper thoracic spine. The indifferent hand roll is almost pure axial traction. But just think, you're tractioning in the plane of this facet. So from here, how do I get there? We'll show you many different ways. Once again, it's up to you. I can stand at the left side. I can contact the left side of that spinous process. I can take out this joint play. Once I feel the joint play has been removed, from here, I'm going to take my hand and I'm going to bring it down as if I'm going to traction up the neck and under the base of the occiput. Now, since the joint's at pre-tension, do we have much motion? No. From here is an eighth of an inch. It's an eighth of an inch spring from lateral to medial, and it's an eighth of an inch traction from I to S. So for the most part, both hands will be moving simultaneously. You're doing this, kind of think as like in the plane of the joint. So from here, I'm just going to lightly spring from lateral to medial, and the other end, different hand from I to S. Another method, same thing, same contacts, just different positioning. From here, what you can do, it'll be easier if I turn the segment around. Just realize my hand contact for this alternate method is going to be the following. I'm going to take my hand, I'm going to place it over, for the most part, like I'd be patting somebody in the shoulder, over the side of the shoulder, so that my thumb is in contact with the spinous. So just so you can see that this is going to be my hand contact. From here, though, it's easier to see from this position. So once my hand is over on the left side of the spinous process like this. Once again, I can just take the head, my hand on top of the crown, and I can passively feel for the joint play. If I want to assess end play, I passively remove the slack in the tissue, and now either A, I'm going to come with this hand contact as if I was sweeping up under the neck and up under the occiput. And from here, I'm going to spring from lateral to medial on the spinous process from left to right, as that hand simultaneously tractions from I to S, up under the neck and up under the occiput. So it would look something like this. And it's only 1/8 of an inch, so it's not gross movement. 2, some people, if you choose, you can use your forearm, the belly of your forearm, as if it was a hand. Since I'm going to place my hand at the base of the neck here, my goal is really, I'm going to take my forearm like it was a hand and do the same thing. I'm going to sweep up under the occiput and up along the posterior aspect of that neck. The hand on top here is just nothing but for stabilization. I'm not going to crank into it. So from here, it's just a question of, through my forearm, I'm going to traction from I to S as I simultaneously push from lateral to medial, in this case from left to right. Now whether you drop it behind their shoulder, or sometimes you'll drop it in front of the shoulder, it's all based on the architecture of the patient. So it's all a question of which feels better, which stabilizes better. This is going to be left lateral bending in a seated position.